So let's get started and kick off the QIck Talks with one of the two teams projects that we had in Cohort 4. Over to you and your team members, Dr. Adeoye.
My name is Adewale Adeoye, and I'm joining this project by Amu Soubolsky and Philip McGee. The title of our project is Reducing the Length of Stay at Saskatchewan's Psychiatric Rehabilitation Hospital. And background to this is that we met up to sort of identify a problem in the hospital. Sorry, I said we are based in North Battleford, and we are working in the Saskatchewan hospital. So we came together, we identified the problem that we can sort of make it an impact on and probably make a change in terms of quality. So we sort of identified that patients in the hospital, as well as the multidisciplinary team, do not consistently know when patients are going to be discharged and the process for the discharge. So in doing this, we went into the data set in the hospital and we focused on 2019. We identified the data set between January 1 and December 31st. And we sort of averaged the length of stay out. And as you can see, so the length of stay is 243 days. And we went into the literature as well to make comparison with that. And the background to this is that after identifying the problem, we wanted to sort of align this with the SHA strategic goal. And we came about with the goal for the project, which is to reduce unnecessary time spent in the hospital for patients and to improve the experiences of patients and the outcome relating to their discharge. And we also identified that it is good to improve on the discharge planning process and to connect a patient to care in the community. These are all in line with the SHA strategic goals. So we came up with our aim statement, which is by December 2020, there will be a 10% reduction in time from admission to discharge readiness for patients on West Peer Review A at the Sask Hospital in North Battleford. We identified West Peer Review A because that's the admission unit, and before patients when they become stabilized, that's when we transfer them to other units within the hospital. Before I hand over to Amy, some of the learning and reflection I've been able to get from the project is that, one, I think it's an opportunity to be on the project and to learn on the project, to attend all the sessions that are provided. Learning process for me, and it's huge. And the other thing is that we started with a very broad aim statement, and it's taken us a lot of time to streamline this into one in order to get focus and to be able to make impact. We discovered that starting with a broad one, we are all over the place, and it was very difficult for us to make an impact on that. But getting coaching from all the sessions we attended was very helpful. And we had to amend our aim statement a number of times. I can't actually count the number of times we've done that. And the COVID-19 pandemic has impacted on our project in a lot of ways because we couldn't go ahead to further collect data. We had to sort of meet sporadically as well, and we had to sort of consider the safety of patients and safety of ourselves in our meeting as well. So these are all very they are good learning points for me. I will hand over to Amu Soubolsky now.
Thank you, Wale. So I'm Amu Soubolsky, and I'll talk about the next part of our project. When trying to really understand our problem, we went through many iterations of a root cause analysis and the driver diagrams. This was our final draft where we felt we really started to categorize the drivers for improvement and had a clearer sense of our possible change ideas. The change ideas that we focused on were to create a discharge readiness checklist and improve the discharge assessment process. We knew it would take a long time to have comparable data to measure the change in the length of stay for our ultimate outcome measure, so we focused on the process metrics and aimed that 100% of patients on the admission unit, West Peer Review A, would have an estimated discharge month by week 4 of admission, and that 100% of the MDRs would use a systematic checklist to facilitate structure and communication. We hypothesized that using the discharge readiness checklist And having a consistent weekly process of assessment would facilitate having an estimated and documented discharge month, which would improve seamless care and reduce inefficiencies in the discharge process, and then would hopefully over time reduce the length of stay. With these short-term targets in mind, we did many weekly PDSA cycles to adjust our checklist content and structure, as well as the facilitation of the MDRs to clearly communicate and document the discharge assessment and the estimated discharge month. So the most significant learning piece I took away was to take time to really understand the problem instead of jumping to solutions. We had to approach the project with many questions and with an open mind, trusting the process and not skipping to our assumed conclusions. I was also reminded that change takes time and problems don't get fixed overnight. There are so many factors relating to psychiatric hospital length of stay, and many of them are related to external resources and out of our control. But we can make a difference by choosing one thing and focusing on one small change. There are many opportunities for future projects and research to address more of the internal and external factors related to psychiatric patient care. And finally, a team that includes many different ideas and opinions adds much strength to the project and opens up many possibilities. Thank you, and I'm going to pass it on to Phil.
Hello, my name is Philip McGee. I'm a nurse practitioner at Saskatchewan Hospital, and I just want to start off by thanking Amy and Wale for all the work they've done being part of the team. Now, one of the things that we did prior to the pandemic is that we really had two change theories in mind, pre and post. The reason being pre, we were like everyone else, trying to unfreeze and change and refreeze and using that Lewin's theory, where we had to pitch ideas and sell them. There was buy-in, was hesitant, change fatigue was happening at Saskatchewan Hospital. We had just moved in. We were under a lot of stress with other dynamics that we couldn't really reconcile. And like everybody else, we had multiple opinions and everybody wanting to add their opinion and wanting their idea to work. The pandemic hit and all of a sudden it seemed like Cotters worked for us. There was a sense of urgency. Everyone was worried about patient safety as well as their own safety. All those barriers that seemed to have been present previously were somehow being moved. So we were really fortunate in some ways for the pandemic because it helped push our project. But there was other ways, of course, where we can all agree systemically it hasn't been great. Our short-term and our long-term decision goals got shorter and shorter, and we were starting to tackle shorter goals, which made it a little bit easier for us. So prior to the pandemic starting, we were using patient satisfaction surveys, impact questionnaires. We were getting in staff opinion, and we were trying to average the time of our multidisciplinary rounds. Reason being is that we started initially, it was 7-8 minutes a patient. When you're doing 24 patients a day, it can get longer. With our goal being 3-minute snapshots of being, what's your job, what's my job? Let's make sure when we reconvene that we've done our jobs. We've had to also change some of the vocabulary used at Saskatchewan Hospital because we were using terms that might have been outdated or that might have had multiple definitions. So we had to really streamline and make sure that we were able to speak the same language. This is what we've created, the discharge readiness checklist that we use at all our multidisciplinary reviews. It kind of gave everybody an idea of exactly what they are to talk about and what they can be expected to bring to the table, as well as it gives everyone the opportunity to know that this stuff will be talked about. So if there's anything that needs to be discussed, it can wait till the specific provider does their job. Like I said, fortunately versus unfortunately, the pandemic provided us a much needed catalyst. We are thankful that we had the idea implemented prior because we were able to start using this virtually. After the pandemic hit, a lot of these rounds went to WebEx like everything else. And once that hit, we felt that we had a flow in place. It was streamlined and everyone just knew what their job was. And as Amy mentioned and Wale mentioned, data collection might have stopped a little bit, but we look at imitation as a form of flattery. We started this on one specific unit, and it wasn't long before the rest of the units eventually picked up the idea and were like, how can we function without this? Some of my learning reflections are people buy in differently. It's amazing how one day somebody buys in and the next day they don't, or what really triggers somebody. You know, is it personal gain? Is it financial gain? Is it patient gain? There's so many reasons why. So that was one of the big learning opportunities for me. A problem for you is not necessarily a problem for me. So the same reason why the buy-in what bothers you today might not bother me, and it might not be a priority. So it was trying to learn what everybody's priorities were and trying to work within them. And I'd like to end on this, is that quality improvement is like a box of chocolates. You never know what you're going to get, but essentially, we're all trying to finish the box of chocolates. Whether you like the cherry one and I like the truffle, the goal at the end of the day is that we eat all the chocolates. So our QI project was simply a box of chocolates that we all shared together. And in closing, we'd like to thank the following people that have helped us: the staff and clinical care team on the West Prairie View A units and throughout Saskatchewan Hospital, Randy Lindquist, the manager, Joe Galloway, our patient advisor and family advisor, Randy Bird, our Indigenous patient advisor, Monica Yohanhan, our quality improvement officer in the Battlefords, Linda Shanker and Dr. Duncan, who are our sponsors, as well as the Saskatchewan Health Quality Council and the Saskatchewan Health Authority. Thank you kindly for the opportunity to present today.